Well, welcome everybody. I'm Don Goldman. I'm the Chief Scientific Officer Emeritus and a Senior Fellow here at the Institute for Healthcare Improvement. I've been here for, over a dozen years. I'm looking at my colleagues here and I think they're agreeing it's been at least that long. During that entire time, my goal has been to bring scientific approaches to improvement so that we can obtain the results that we'd like to see to help improve health and healthcare. Along the way, though, there have been a lot of changes in the healthcare landscape, as you well know, and it's really requires a lot of expertise to keep up with this because we're not payers here, we're not a hospital system, and we're certainly not health economists. So we've reached out to some really extraordinary people to help us sort through some of the issues that you're all facing, particularly in how we can pay for and support the care that our most vulnerable patients need. Those of you on the phone probably are familiar with the playbook that has been put together by IHI with a lot of support and funding from 5 foundations, Robert Wood Johnson, SCAN Foundation, John A. Hartford, the Peterson Center, and the Commonwealth Fund. And this online playbook contains a number of approaches that really rely on an understanding of how we would provide payment and service to patients with complex health and healthcare needs. The playbook's organized around 4 questions. Why would we invest in this patient population? I think I don't have to persuade any of you on the phone about that. How do we, I don't really like the word, but how do we segment the population so we know exactly who it is we're trying to help? What are some of the most promising care models that we can test and hopefully begin to spread? And what are some practical tools, or as we call them, plays, that people can start using to make progress on helping people with complex health and healthcare needs. So that's where we're going today. During this webinar, I hope you'll chat in some questions through the question answer button at the bottom of your screen. And we've got a whole team taking account of what you're saying, and they'll be funneling questions to me and to the experts we have. With that, let me welcome our 3 distinguished guests. I love this. This is not a free advert, but I love the Zoom platform. I can see them. They're smiling, which is a good thing. I know that before we started, they got some coffee, as did I. So we're all set. And I hope those of you who are at home or in the office are all set too, because we can't see you and you can drink and eat as you please without worrying about seeing, whereas the folks I'm seeing, if you haven't had your lunch yet, too late. You have to wait an hour. So the 3 folks we have joining us today are Diane Hasselman, who's Deputy Executive Director of the National Association of Medicaid Directors. And she's going to offer her perspective on how states are using Medicaid doctors in particular to care for vulnerable patients. Michael Baylett is the founder and president of Baylett Health, and he's closely attuned to what's happening at the state level, and he'll be giving us insights into how states are implementing value-based payment for long-term services and supports, services that this particular population really relies on. He's worked very extensively with public agencies, purchaser coalitions, and employers to advance the effectiveness of the healthcare purchasing activities they're engaged with. And then finally, I'd like to welcome the very noted payment reform pioneer, Suzanne Del Banco. She's the executive director of the Catalyst for Payment Reform, which is an independent, not-for-profit corporation. And she'll be providing insight on emerging trends and developments in payment reform. And some of you may remember Suzanne from the time she took the big step of being the founding CEO for the Leapfrog Group. Let's turn now to the panelists because, full confession, I'm not the expert you want to hear from. I'm good at asking tough, provocative questions, not so good at any of the answers. Diane, do you want to lead off, please?
Sure, absolutely. Can you all hear me okay? Yay, wonderful. Great. Well, thank you so much. Really appreciate being asked to present this afternoon. Greetings from Washington, D.C. So what I'm going to do is provide kind of the 64,000 foot view, the national perspective of Medicaid. I'm going to tell you a little bit about the population that's covered, a little bit about how dollars are used, and then provide a couple of contextual points to keep in mind as Michael and Suzanne talk about, get a little more into the details about the models. So, and many of you may already know these, but let's just kind of ground ourselves in some level setting. So, so Medicaid, as you probably know, it covers about 74 million Americans. That's about 1 in 5 Americans. Medicaid covers 50% of all births in the United States. In terms of the covered population, the breakdown of the Medicaid enrollees, it's about 25% are elderly and disabled, about 40% are kids, 22% are adults, so parents, moms, and then about 13% is the expansion population. So these are childless adults. In terms of the complex population, Medicaid covers 6 in 10 nursing home residents. It covers about 44% of kids with special healthcare needs, so Down syndrome, muscular dystrophy, cerebral palsy, autism. And very interestingly, about 30% of people who have an opioid addiction are on Medicaid. This is largely the expansion population, and an issue that comes up with the expansion population. Coverage, eligibility coverage varies state by state. So every state can decide the level they want, who's covered, et cetera. Whether they want to expand or not. So there's a lot of variation state by state. So that gives you a snapshot of kind of who we're talking about. Shifting then in terms of dollars. So Medicaid now is more than $500 billion, the program. It's about 17% of our national health spending. It's expected to be about $957 billion by 2025. Medicaid is the single largest payer of mental health services, so it's essentially our country's de facto mental health system. It's our de facto long-term care system, as I said above. In terms of financing, it's a federal-state partnership. So the feds will pay anywhere from 50% to perhaps 75%, and it just varies. And it's based on the average per capita income in that state. It can range to be about 25% of a state's budget, sometimes a little bit more, sometimes a little bit less. And it's typically second only to education in the state's budget. What is covered and the cost, again, varies significantly state by state. So this is not a Medicare program. That's just something important to keep in mind. So that's kind of an overview of some of the cost, the amount of dollars we're talking about. I want to just give 2 contextual realities to keep in mind, and then turn it over to Michael to dive deeply into some models. I think the 2 things to raise is delivery system and payment reform are an absolute top priority of Medicaid directors. 40% of Medicaid directors last year said that they were prioritizing delivery system and payment reform. So implementing patients that are medical homes, health homes, ACOs, episodes of care, et cetera. So it is front and center for Medicaid directors. Similarly, it's also front and center to shift Medicaid beneficiaries out of institutional settings into home and community-based settings. So nearly every state last year took action to do this. So that is front and center for states and Medicaid directors. The second contextual thing to keep in mind is the role of health plans. 39 state Medicaid programs contract with risk-based MCOs. So that means health plans are really the primary partner in the vast majority of states. And states delegate program design decisions to health plans. So that's important. 28 states have at least 75% of their beneficiaries in risk-based managed care. Although elderly and disabled individuals are least likely to be enrolled in risk-based managed care, but 34 states have some percentage of elderly and disabled individuals in MCOs. So that's important to keep in mind. So those are my kind of opening framing remarks, just setting up the population, the number of dollars we're talking about, and some context. So, Michael, can I turn it over to you?
Thank you for the baton toss, Diane. It's a pleasure to dialogue with you and Suzanne today. So I actually want to build from the words that Diane just shared, and I want to build specifically from her conveying that payment and delivery system reform are a high priority for state Medicaid programs, and the state Medicaid programs are primarily doing their purchasing through Medicaid managed care plans. So the way that has manifested itself is that increasing numbers of states have written into their contracts with MCOs, from Louisiana to Michigan, from Oregon to New York, specific contract language that directs their managed care plans in sometimes very quantitatively defined terms, in other cases less so, but very specific terms about how they expect to see their plans expand the use of value-based payment methodologies over time. What this has meant in most cases is that health plans, Medicaid health plans, have implemented with Medicaid providers new payment models specifically for primary and acute care, and typically for the majority of their population, but not for their most complex needs population. So I'm going to describe right now, just to get us started, what are some of the specific challenges with trying to do value-based payment for complex needs populations. And when I do so, I want to start with, so what do we mean by a complex need population? The complex need population is actually many different smaller populations. It is a heterogeneous group. And many, but not all of them, have Medicare coverage, which makes the purchasing and payment strategies complicated for states, because states are only paying for Medicaid services and not Medicare services. But what are some of these populations? I just want to give you a feel. So this would include seniors with dementia, adults with developmental disabilities, adults with complex physically disabling conditions such as neurologically based conditions, seriously mentally ill adults, and children and youth with special health care needs. So very heterogeneous population. Many of them use long-term services and supports. These are not traditional healthcare services. The next challenge, in addition to the heterogeneity of the population, is that the providers of long-term services and supports are to a much greater extent than for medical care, are mom and pop providers. They're very small. They don't have a lot of infrastructure. And so it's challenging implementing value-based payment methodologies with very small providers that don't have even basic capabilities to do performance measurement. A third challenge is that because of both subpopulations, heterogeneous populations, and the fact that many of the providers are small, in doing value-based measurement, which is needed for value-based payment, you run into the problem of small numbers. or the small n problem. It makes performance measurement and evaluation very difficult, and it makes it nearly impossible to assign financial risk to providers. Fourth challenge is there are few standardized measures of quality for long-term services and supports. And in addition, where there might be measures, there aren't available benchmarks. And benchmarks are important for value-based payment because you need to have some basis for assessing whether performance is good or bad. And without a benchmark, it's hard to do so. So these are all the reasons that states, while moving really headfirst into promoting value-based payment, have been much slower to do so for complex need populations. Now, some have done so, and I'll talk later on about how they've done so and suggest how this work might be done. But there are some distinctive challenges to doing value-based payment specifically for these populations and services.
Okay, so that's terrific, Michael. Let's move right on to Suzanne. I was tempted to ask you a few questions. It seems so challenging to me to deal with small practices, big health systems, and bundles and ACOs and fee-for-service. But you can be thinking about all that, and let's go to Suzanne now.
Thank you, Don, and it's a pleasure to be with Diane and Michael this morning. Diane, I love your posters behind you. I'm talking to all of you from the San Francisco Bay Area this morning, and I can see some of our lovely parks featured there. So I'm going to take a big, left turn and go in a different direction. I was asked to share with you the state of payment reform in this country, sort of writ large, not necessarily specific to complex patients, but then share a few thoughts on maybe how some of these trends may be relevant or irrelevant to the needs of patients with complex situations. So just as a little bit of background, my organization, it works with employers and other big purchasers of healthcare. So we actually work with several of the most progressive Medicaid agencies, as well as state employee and state retiree organizations. So we've got a diverse pool of healthcare purchasers in our group. And we have been pushing for payment reform for 7 years because we think it is an important ingredient to achieving a higher value healthcare system, better quality and more affordable care. So as we have been catalysts for payment reform, we've also tracked how much payment reform there is and of what type. And I'll tell you that when we started in the summer of 2010, between 1% and 3% of payments were tied to performance in some way. And now as a nation, probably about 50 cents on every dollar has some kind of a quality connection to it. So either, as Michael referred to, there's performance measurement that has to happen and a provider's payment is contingent on their performance, or the payments are designed in such a way to enable improvement in quality. So we've really come a long way, although I would say we're at a stage where there's a lot of payment reform, but we're not exactly sure what's working. So we're still, in my view, 7 years in, very much in an experimental phase where we need a lot more evaluation. But what I will tell you is that the fastest growing category of payment reform when we got started in trying to push for it was pay for performance. And maybe that's no surprise because people had already done it a little. And so expanding that was an easy thing to do. And that basically means potential upside bonuses for providers when they hit certain quality targets. Now we're seeing a close competitor of pay for performance is shared savings. This idea that certain quality standards must be met, but if providers manage to beat a budget that's been set for them for a certain population of patients, they get to share in some of the savings. Eventually, where we see this evolving is more risk, more financial risk on providers. Right now, for the most part, we have payment reform that offers potential upside to providers as a carrot. But eventually, we anticipate that there will be more and more financial risk placed on providers, especially those who can handle it, the larger groups, the bigger practices, the health systems. And so we'll see some evolution there. We're not seeing any growth in capitation right now. I live in California where there's a lot of it. There's a lot in Minnesota, some in Massachusetts, but there's really not a lot of growth there. It's much more using the fee-for-service chassis and putting on top of that sort of bells and whistles, which are, you know, quality connected or spending connected, to say, you know, we're going to add some incentives on top of the perverse incentives of fee for service to try to, you know, correct some wrongs and line up the incentives as well as we can. Bundled payment gets a lot of talk. The idea of paying a package price for a set of services for a patient, and this could be very relevant to patients with complex needs, but we're still less than 2% of all payments in this country flowing through bundled payment. So a lot of promise there, some good results from some evaluations, but health plans have not figured out how to automate it. A lot of providers are not quite sure how to handle it. Who gets the payment? How do I distribute it? So there's a lot more conferences and discussions about bundled payment than there are actual bundled payments. So I think I should, let's see. When it comes to complex patients, I am not an expert on this topic, but what I would say, to state the obvious, is that care coordination is obviously incredibly important. And so what's promising about some of these new methods of payment, shared savings, shared risk, and even bundled payments, is that because they're a larger payment for a bigger set of services over a bigger period of time for a given patient, there is more incentive for providers to have to work with each other to make sure to avoid redundancies, to get care done right the first time, et cetera. And obviously that's advantageous when there's someone who needs a lot of care. In the early days, we have seen specific payments for care coordination. So whether they were sort of the base payments made to patient-centered medical homes or accountable care organizations, I guess I shouldn't call them base payments, but sort of they have their base fee for service payments plus a care coordination fee, and then on top of that, the potential of some kind of bonus or shared savings. Over time, we're seeing that payers want to phase out those care coordination fees and really focus on the quality metrics and the overall spending, and hope that by less piecemeal approach to payment, that providers will have an incentive to figure out their own care coordination and invest their own dollars in that sort of approach. The last thing I just want to mention is that, as I said, almost all payment reform today is based still on fee for service as the foundation. And the one thing that we really shouldn't ignore is how flawed the fee schedule is. That is the basis for all these approaches. So sometimes we pay too much for things that should happen less often, tests that are overdone. Sometimes we pay too little for things that should happen more often. And sometimes there are no payment codes at all for things that we should be paying providers for. An example would be, you know, email visit or something like that. So another thing I think we should think about with this population is, are there things that are flawed about the fee schedule that underlies all these new methods of payment that we would like to address? So with that, I'll turn it back to you, Don.
Yeah, so it's easiest to start sometimes with a person that just said things that raised some questions. So I'll start with you, Suzanne. So I thought, in my naive way, that the goal was to get 70% of care on alternative payment models, and that we were well ahead of that pace. That, at least that's what the proponents of the ACA said. So I'm a little bit floored to hear that we haven't really gotten there by any stretch of the imagination. So that's one question. What's happened? Why aren't we where we need to be? And the other question, which really others can chime in on, I have pretty profound skepticism in the ability of pay for performance that are based on the quality metrics we have now. They seem very narrow, they're condition specific. The patients we're talking about today have multiple comorbidities, and getting their hemoglobin A1C in range or their blood pressure down may not be what their care is all about. So the two questions: why aren't we making faster progress to APMs, and how can we possibly build a system on narrow, incomplete quality metrics? And others, please feel free to raise your hand and jump in.
Yeah, so on the first comment, I'm not sure where the 70% comes from. Maybe that's from Secretary Burwell's goal that she set for the nation. I should remember the goals better, but CMS basically feels like it's a pace as to where it wanted to be with how many alternative payment models are in place. But what I would say is that as much as I've been a proponent of payment reform, I don't want to be a proponent of stupid payment reform. And so more is not always better if we don't know if it works. And so I would say, we need to take a slightly sober approach as we're changing payment models. Let's continue to evaluate them, see how they're working, see if they're leading to the impact that we want them to. And obviously having the right quality measures is part of that assessment, because you want to know, are these new payment approaches improving quality? Are they avoiding some potentially scary unintended consequences? Are they helping us get to more efficient delivery of care and more affordable care? And so, to make a judgment on whether or not 50% of payments no longer being traditional legacy payments is a good or bad thing, I think it's all about the quality of those payments and what they're leading to. And we're actually embarking on a new project where in 3 states, we're doing what we call Scorecard 2.0, measuring how much payment reform there is, what types, but also what kind of impact is it having on the healthcare system? And I think that's what we really need to start looking at. So that's your first question. And then your second one, now you're going to have to remind me because I already lost it.
We can let somebody, you've been talking a while anyway, so we'll let somebody else, either Michael or Diane may want to handle this. I was commenting that I'm not a big fan of pay for performance in general, and I don't think, this is my personal opinion, that the quality measures we have right now are appropriate for pay for performance for patients with complex healthcare needs. So Michael or Diane, do you want to launch into your opinions on that? Am I out in left field and being a usual radical, or am I on to something there?
I'd be happy to respond. So yeah, the evidence on pay for performance programs is not very compelling. I'll also say though that for small providers, like those small long-term service and support providers I referenced, it may be the only viable option because of their size. And so I think there may be a space for pay for performance programs, but a narrowly defined space. Your other comment on had to do with measures, and certainly the types of measures that we need for complex care populations are different than what we need for others. Measures of quality of life, of functional status, of independence, those are things that matter the most for people with complex conditions who need supports for daily life activities. And we do not have a robust system for collecting that information, nor for using it for evaluative purposes that would support value-based payment. And I'll note that this type of information can be challenging to gather because it requires, if not a survey, sometimes an in-person interview, sometimes an in-person interview with a facilitator to gather the information. It's really difficult work to do.
Diane, what are your thoughts on this? I find it kind of amazing, really, that we have an enormous infrastructure in the United States to collect hemoglobin A1C, but we apparently find it incredibly challenging to find out how people's quality of life is. From a Medicaid perspective, it really all is about the quality of life in patients who have social determinants that are making it hard to achieve even decent health. Do you have any perspective on this? Why is this so challenging? I mean, we live in the electronic era here.
Yeah, no, I think that's a great point. And I think from the Medicaid director's perspective, I think they would totally agree that the important thing is to have measures that are meaningful. I think the challenge is many states struggle to have the infrastructure needed to collect these data and to do this work, just as Michael was saying. I think that is a huge challenge. They may not have the expertise in-house as well. So, but I think Medicaid directors are totally agree that we need to have meaningful measures. I think the other point I wanted to make, just to build on what Michael said about P for P is it's not only appropriate sometimes or sometimes the only thing for smaller providers, but it also can be a good on-ramp for providers that are brand new to the concept of moving away from fee for service or looking at quality, et cetera. So I think there are some good reasons to keep P for P going.
A quick follow-up to that. So the small provider is challenged under the current P for P system because they may not see a high enough volume of patients with any given condition, and many of their patients, especially Medicaid, are going to have more than one comorbidity. So it seems to me almost impossible to correctly reward them or penalize them or incentivize them using traditional measures that we have now. What do Medicaid directors do to perhaps lobby for or create the conditions where we can measure what any provider can look at, which is, are their patients healthier?
That's a good question. I'm not sure if I have an answer off the top of my head. I think it's challenging when there are small practices, independent providers, possibly trying to perhaps aggregate data or information or performance, but it's definitely a challenge.
Well, we're starting to get some questions in the queue, but I have a couple more and then we'll turn to them. I'm intrigued by the issue around bundled payments, and maybe Suzanne, you might want to tackle this. There's an awful lot of hype about this, and I know the professional societies, especially, for example, orthopedics, are spending hours, if not days, at meetings figuring out how they're going to deal with bundled payments, and to deal with a confusing situation in which some of their patients are a part of an ACO and others are on bundled payments, others on fee for service. Bundled payments have a lot of support among some of the intellectuals. Do you think they're fundamentally flawed and we should just move to more fully capitated models, or what do you see as the future?
I mean, I'll be honest here, as I usually am, and say that I think there's a lot of support for bundled payment all around. I think the health insurance companies who have legacy systems in place for facilitating claims of the way that they've always done have been resistant to making the investments needed to really be able to automate these bundled payments. And that's been a real, sort of rate limiting factor in their growth. So I don't think it's that they're just flawed and we shouldn't do them, or that there's, resistance in this camp or that camp. I think it's a mechanical issue in many ways. There are certainly a lot of philosophical things to figure out. Who receives the lump payment? How does that get disseminated across the different partners, especially if it's not in, one big health system where they all are employed by the same, provider? How do you trust, that the dollars get allocated correctly across everybody involved in that patient's episode of care? So there's things to work out. But I mean, we've seen, going back to Medicaid, we've seen some wonderful examples in Arkansas and Tennessee where they've brought together panels of experts in the state. They've made these decisions. They've come up with some standard approaches in terms of what the quality measures are going to be, how you define the episode, and then they've been able to sort of go to town and really spread these much faster. So I think it's about will. It's about the willingness to make investment more than it is that there's some mechanical problem. It's not that it's easy, but it is doable. We've seen it.
Michael, speaking about challenging issues, you mentioned people who have disabilities and both physical and severe mental illness that really makes it hard to make progress on improving their overall health. And in addition, we have children, as you said, with special health care needs who, since I work at Boston Children's Hospital, I know just how challenging it is to meet their needs, especially outside of the hospital. Any observations on what we can do to improve care and services for such people?
Well, your question is beyond value-based payment, how to improve care for them. So what I'll address is, so how can you use value-based payment in a way that will support improved care? What I've seen, I talked earlier about all the challenges in applying value-based payment for long-term services and support. So what a bunch of states have done is tied quality incentives instead to meeting their healthcare needs. A lot of these complex needs populations have lots of healthcare disparities that are related to their disabling condition, and they have lots of comorbidities. So, for example, there are programs that focus on persons with disabilities that focus, or on seniors, let's say, that focus on them getting basic primary care, because they may be less likely to get a flu shot, they may be less likely to have well cares, screenings. Those are easier to measure, and the entity that can be held accountable could be the healthcare provider, but it could also be the personal care attendant or the home care agency that's given responsibility for helping to arrange for the clients that they're serving to receive some of those services. So, in fact, what we've seen in states is that actually states and their health plans have done more in that arena than they have to try to attach value-based payment to long-term services and supports. Does that answer you, Don?
Don, you might be muted. Oh, there you go.
Yeah, I got it. Yeah, it suddenly, everything disappeared from my screen. Just one more question that Michael brought up. Maybe Diane want to tackle this. You mentioned, Michael, disparities, and there's almost nothing in the way of healthcare quality metric you can look at that doesn't show lack of equity in the United States. And in Medicaid, I'm sure we're extremely focused on that issue. How do we build that into the incentive programs we're talking about? As far as I know, there's only one macro measure that has anything to do with disparities.
That's a great question. Unfortunately, I'm not an expert on quality metrics or those that focus on disparities, but I would imagine that health plans and Medicaid there's some construction right outside of my window, so hopefully you won't hear that. But I would imagine that health plans and Medicaid programs would be trying to look at their quality data, trying to stratify it by race or ethnicity or language or income levels or even rural, urban areas, geographic differences, to try to identify disparities that exist and try to come up with that local community or set of providers to try to identify what are some of the interventions, some of the ways that Medicaid health plans or the community or the state could help improve the quality of care for populations that are facing inequities. That might be one way to approach it.
Yes. Suzanne, do you think that we ought to just adjust away these differences so that we can have fair payment to providers, or should we be explicit and say, you have a disparity, show us that you're actually reducing the disparity? How would you approach that from I'd say, an equity and ethical point of view?
Yeah, I mean, this is Suzanne Delbanco's personal opinion. It's not something that I've worked on too much through CPR, but I know that risk adjustment will be debated forever. How do we account for all these differences properly? And I think the disparities are so great in this country that we should be measuring it directly. I think that we've learned, a catchphrase that everybody knows now that we didn't know 10 years ago, social determinants of health. It's a real thing. There are people who have, structural challenges in their lives that, make healthcare not a priority or feasible. So, I think if we don't measure some of these things, whether it's race, ethnicity, social determinants issues, that we're just going to be ignoring some things that we need to address very directly. And, there have been fascinating studies, how do you address the needs of homeless people? Well, it turns out, if anyone's read Malcolm Gladwell, maybe give them a home instead of all these services we try to do that don't address the core problem. So I think we have to recognize how healthcare and other aspects of people's lives are integrated and address that head on.
I'm
Don,
just
if I
going
could just add
ahead.
on to what Suzanne said, sorry, and that is that there are state Medicaid programs that are having their health plans do screening for social determinants of health and trying to identify what are those needs up front and to be better skilled at addressing those.
So I'm going to ask some of the questions that were chatted in by the folks on the line, and I'm just going to ask what they ask, and whoever thinks that they have an answer. This is a particularly interesting one, I think. What about accountability of the patient? So it seems like all of the emphasis here is on accountability to the provider and the provider team. Don't patients bear some responsibility? I think that's what this person's getting at when they ask the question.
And this is Diane, I can just jump in because there's actually some very interesting activity going on in the states around personal responsibility. Several states are very focused on and have submitted what's called an 1115 waiver to the CMS administrator to try to link, for example, work requirements or lifetime limits or drug testing, those are examples of what falls into personal responsibility, to tie those to Medicaid eligibility. That is one way that, again, at a very high policy level, Medicaid directors and several states are trying to bring in that personal responsibility. That's a little bit different, Don, than what the person is probably asking on the in terms of the question. That's probably more of how do you get the Medicaid beneficiary directly engaged with the provider. I'm not sure this is an issue that's unique to Medicaid, but it certainly is an important one.
Yeah, it strikes me, if I can just give my own personal opinion, that the blunt instrument of policy and personal accountability and being hale and hearty and able to work is really tough to apply to individual provider-patient relations that are very often not so simple. Do you think that policy hammer is going to be useful, or is it just a political position?
Great
You don't
question.
have to, it's off the record, right? In front of 300 people.
Yeah, I mean, this is Suzanne, if I can jump in. I mean, the one thing that I would add is we've done a lot of thinking about in the commercial market, how do we need to line up the incentives of the patient with the provider? So for example, if a provider is being held to account for, we'll use the HbA1c measure, for making sure that people with diabetes have their blood sugar tested every 3 months, and the patient has a high deductible plan that doesn't provide first dollar coverage for their HbA1c test, well, we've got a clash there. And so we have to start thinking about how to enable the patient and the provider to work in concert with each other as opposed to being at odds. So I'll just leave my comment there.
Question now for Michael. Let's move on to a slightly different topic. Behavioral health is just so important. I know you touched on it briefly, but what are the forces, the incentives, the policies that are going to help providers, especially in smaller practices, really focus on this issue? Because people who are depressed or have more serious mental health problems aren't going to be able to, measure their blood sugar at home or whatever, or take their meds. It's going to be a problem.
Well, we've actually had some measurement technical innovation in mental health, at least for depression, which is the example that you cited. There is a measure initially developed by Minnesota Community Measurement that's now in the HEDIS measure set that looks at using a standardized tool for diagnosing depression, for doing periodic follow-up, and for measuring remission. Depression is one of the very few places where we actually have a measure that assesses outcome. If we only had more examples, and we don't have more examples outside of depression. In fact, there are very few examples of standardized quality measures that exist for other common mental health diagnoses. If you want to look at anxiety, which is the second most prevalent mental health diagnosis after depression, there really are not any good anxiety measures. And so there are lots of challenges still for behavioral health measurement to support value-based payment. Don, also note, you said for small practices, we will always have a problem with value-based payment for small practices because they simply don't have enough patients to be able to reliably measure their performance and in some manner to reward them. And this small number issue is a challenge in every state, particularly where you have lots of small independent practices that are serving the Medicaid population.
You know, one of the temptations is to call on technology to help get us, to help advance what we're trying to do, especially in the field of behavioral health. So in the United States, there's a lot of work now on virtual cognitive behavioral therapy. England has a program in NHS to have better screening and virtual treatment for patients with mild to moderate depression. Are these things reimbursed now, and do you even think that they're what we should be trying to finance?
I'll be honest, I don't know to what extent alternative treatment modalities are covered by states. Maybe Diane has some sense about it, but I don't.
Yeah, Diane, what do Medicaid directors do? Are you guys aggressive in trying to say, look, there are these technologies that are going to help folks deliver care to this population? Can we get coverage for them? How do you actually lobby, especially when you have, what is the phrase? If you've seen one Medicaid state, you've seen one Medicaid state.
I think health plans are probably the vehicle for providing using technology to address behavioral health conditions and deliver services in a new way. And Michael, I'm not sure either if they are out there, but I would imagine that Medicaid health plans are paying for and covering visits, for example, through a Zoom or through a Skype, et cetera, for behavioral health conditions.
Yeah, I could just share quickly that for in the commercial market they are.
And does that include telehealth, especially one of you mentioned Arkansas, people who are living in rural areas, I would think telemedicine would be very important. Is that uniformly covered now, or is it you have to understand how to get it covered?
I wasn't sure, Don, are you asking in Medicaid or in commercial?
Just in general. So can I count if I'm living in the Bayou in Louisiana, Cajun country, and I've got diabetic foot ulcer and I want somebody to look at it, who's going to help me figure out whether it's covered, and in fact, is it likely to be covered?
Yeah, I mean, I can just speak to it. The commercial market, it's typically communicated through the health plan. Some large employers have contracted with telehealth vendors directly themselves. I'm not sure about in the Medicaid department, but I will also just say it's, telemedicine, as it used to be called, really started out to help people in rural situations. It's really everywhere now, and it's the idea of increasing access to primary care services, to behavioral health services in different ways that different types of people might be more comfortable with or might find easier to access.
Michael, this is a question, there's somebody chatted in a question about children with complex healthcare needs. An individual takes care of a lot of such patients. What we would really like to do is have children in the home getting the care they need. I remember at Boston Children's when the first patient went home with a ventilator, which was a huge thing. Are we making progress there? Are we still, you come to our tertiary quaternary care center and we'll take care of you, or have we managed to provide and pay for, even more importantly, the services that people need to care for their very complex patients and children at home?
So this is both a payment and a coverage question. So I'm going to put aside the coverage question, whether it's covered in the home. But traditionally, we've paid tertiary centers a lot of money to deliver the services at the center. There is an opportunity through payment models to give them an incentive and some flexibility and opportunity to deliver those same services outside of the expensive tertiary center, and maybe in a setting that's more desired by the family and by the child. The person who asked about payment models for kids, children with complex needs are often served by children's hospitals where the specialists reside. There aren't a lot of them served in the community. Because there's a concentration at these centers, it's possible to develop a total cost of care payment model for the hospital that's viable because they've got enough volume to make it work. And I've seen that happen across the country where there are Medicaid populations that are covered in a total cost of care arrangement between Medicaid health plan and the children's hospital. That's something that's not possible for kids who might be supported by a community-based practice that's seeing very small numbers of kids, but it is possible to do with a big medical center.
This question, I'd love anybody to answer, just raise your hand or chime in. I'm just a country doctor and I'm sitting here in my practice and I've got to deal with some patients who are Medicaid and some patients who are on a private insurer and some patients who are on some sort of ACO that carved out my particular patients. I may have 5 payers and the government, and it's virtually impossible for me. I'm burned out. I'm going to join the hordes of people retiring early and just throw up my hands and say, let me know when you got the profession I signed up for. Anybody want to help me feel better?
Well, so we've got to do things to rationalize the world for you in doing that. So one thing that states have done is to try to create aligned measure sets so that all of the payers, be they Medicaid or commercial, are writing in the same performance measures into the contract between you and your organization. Let's say it's a large practice, or you're part of Children's Hospital, then with Children's Hospital. There are ways that we can get some basic alignment within the marketplace so that you're not driven crazy trying to understand what each of the payment arrangements is trying to motivate you to do.
Anyone else want to chime in? I think I would just say, as that burned out physician, that we have a way to go. And I may be gone by the time we figure that out 10 years from now. Anyone, I'm being provocative, right? But Diane.
You're right. You're right. We do have a way to go.
Yeah. So I read in the paper this morning, I read the Wall Street Journal, has really good medical coverage, and then I'm selective which parts I read. But there was an article about consolidation of health systems. Ascension now is looking at acquiring additional hospitals, the biggest health system in America, I think now, and others are joining forces. And the impression I got reading the article and what I've seen over the last year or so is let's buy up and control as many providers as we can so we can essentially buy up and control as many patients as we can so that we can simplify the system and make it more cost effective. Suzanne, would you comment on that? Is that rational? Is it going to help, or is it just going to be harder to make change because the power will be so concentrated?
I hate to be the bearer of bad news, but there's been a lot of research on this, and consolidation among providers without variation raises prices, and there is no evidence that it improves quality. In fact, there was a great study done just recently of providers providing care to Medicare patients in patient-centered medical homes, and the higher priced providers had no improvement in patient outcomes. It's a great story that when providers come together, they're going to improve efficiency and they're going to make care more affordable for everybody, but they have yet to pass on any savings, if there are any, to any of us who either use healthcare or pay for it.
Diane, do you want to chime in from a Medicaid perspective? How does all this consolidation affect care for Medicaid patients?
I guess I wouldn't chime in from a Medicaid perspective because I don't think this is a Medicaid problem. I mean, I think it affects the whole healthcare system, or it's not a problem that's just unique to Medicaid. So I would say it is affecting everyone, and certainly I think Medicaid programs, and it varies across states, but it can be challenging to attract providers, specialists in particular to the Medicaid program. So to the extent that that could influence or impact or make it even harder, I guess that would be a Medicaid perspective, but consolidation certainly impacts all of us.
Great. So we're just about out of time. I'm going to do a real rapid fire. This is a little unfair, but if you had 1 minute, each of you, to advocate for a change in the way we pay for care in the United States, what would you advocate for? Suzanne, why don't we start with you?
Sure, I'll just underscore points I already made and take less than 60 seconds. One is that we need to look carefully at the Medicare physician fee schedule, which is the root of all the payments that we make in this country, whether it's in Medicare, Medicaid, or commercial, and really rebalance how we're paying for different things based on what they do for patients. And the other thing that I would say is that I forgot what the second one was. So
That's okay. You used your 60 seconds. I'm sorry. Diane, your turn.
I'll jump in, and I guess from my perspective, the comment would be that we would hope that CMMI and CMS continue to keep their foot on the pedal, the gas pedal, to move forward with bringing Medicare to the table and advancing alternative payment models in Medicare. That just makes it easier for Medicaid and other payers then to follow suit. And the train has left the station on alternative payment models, and we need to keep moving forward.
I was going to say we need to.
No. Michael's turn.
I was going to say we need to evaluate programs, and that builds on what Diane said. Go ahead, Michael.
I would say we need to use budget-based payment models that involve providers assuming meaningful downside risk for most populations, but for complex care populations, we need to do something that's different and customized, or else their needs will not be met.
Okay, and just to be fair, I get my 30 seconds, and it would be to remember that our goal is to improve the health and healthcare of all Americans, and maybe if we start from the principle of population health and equity, we'll come up with some innovative payment models that aren't so focused on quality metrics and health systems and oh, good, I'm getting some applause from Suzanne on the screen, good. But I really feel that that's a perspective that we sometimes lose. So I think we're at the top of the hour. This has been incredible fun for me. I hope you've all enjoyed it. I hope I haven't been too provocative or put you on the spot, but I really appreciate you've taught me a lot, and I'm sure the folks who've been on the line have learned a lot as well. Thank you so much.
Thank you.
Thank you very much.